back up. We're bringing Dr. Weibel back up to kind of talk about spirometry. This is something I feel like even those of us who have done it for a long time, it is good to re-review, because we were just talking the other day about how probably every one of us, someone in our office can do this better than we can. And is that okay? You know, most of the time, yes, but it's good for us to know.
You can hear me? Yep, great. All right, so I did rename the talk. Of course, there's this book out there. Well, slides always take a moment to advance.
Point it this way.
There we go. This was going to be the talk, but the book isn't out there. So I thought maybe we'll just talk about some of the aspects of nuts, bolts, and some about everything else with spirometry. So again, thank you for having me. Of course, you have my email. If you don't, you know where I live here in San Antonio. You just let me know. I have no disclosures, and unlike Dr. Silvers, I don't plan on getting any new disclosures. So my objectives, hopefully, is to understand a little bit about spirometry. Really, though, it's your staff. And just show of hands, those are in clinic. Raise your hand if you're doing spirometry. Okay, so keep your hands up. You're all providers, right? No one's an MA. Is anyone an MA here? So how many of you in the past 6 months have been the person in the room that you are doing the spirometry with the patient? So I'm glad some of you are still doing it. Doesn't mean the people that drop their hands, that's fine too. But you just want to make sure what's going on in the room is actually happening the way you want. And you'll get that report, but hopefully this lecture you'll have some good takeaways for that. So what you're getting is quality. So I read all these, so you don't have to. But if you want to go into them, you can. And actually some of these are pretty recent updates. 2023, 2019, with ATS and the European Respiratory Society. So I use these as my references. So what is, of course, the role of spirometry? You know, we're measuring lung function. It's obviously the most common pulmonary test we're going to do likely in our clinics. And we're measuring different things, and we're monitoring different things, determining prognosis over time. We don't do too much, I think, pre-op assessment, but maybe you get a patient who's going to head to the OR and they want to have you do a spirometer. So we know, just like the topic of EOE, you know, the symptoms can often not correlate well with biopsy results. Well, the same goes with pulmonary function testing and asthma symptoms, right? Everyone should be doing their asthma control test or some other validated scoring, and you've probably noticed how sometimes that wildly differs from their spirometry results. So I'd encourage you to get the symptom scores, but then the objective spirometry measurement. And you can see how, based on the spirometry, sometimes things get classified differently, so use both tools. And then some people, of course, we'll talk about peak flows just briefly. It is helpful, but really the spirometry is much better in terms of getting that full lung function. So I thought, how can I break this down? And I broke it down into kind of these 4 focused areas. First one is just setting up the room that you're going to do the spirometry in. So you wouldn't think like, oh, you just go in there and do it, but when I worked in the military hospital, every morning we'd have to go in there with our 3-liter tube and kind of calibrate the machine and write it down because Joint Commission's coming. So I thought, well, like, I've never calibrated this machine since I've worked at Aspire. Is that like a thing? And fortunately, I found this reference, which used, I think, a device that most of us have in our clinics, this Easy One. And the study that went with it, they did over 4,000 different speeds, different techniques, and basically there's very little variability, effort to effort. So your spirometers are good, and if you're calibrating them, I guess great, but you don't have to, and you have a reference to support that. Inputting the data, right? When your MAs put the data in the machine, it should be correct, and to me the biggest thing is always the height. If you're not getting a correct height, and again, back in the day, we'd had stadiometers that were bolted into the wall, engineered to get a perfect height. You should definitely do your best to kind of try to make it level, because if you mess up on the height, it's going to totally change your lung function values. Hygiene. We wash our hands, right? But maybe there's something more to this. Again, these are some of the guidelines that are there, but you know, are we having our patients wash their hands before they touch your device? Are they coming by with the cavi wipes and doing that? I'm not saying you have to do it, but just realize you're touching all this stuff. So are we washing our hands before and afterwards? And a lot of, and this is me, and I was thinking about this, I was going to talk to you, is, the MA comes in, I have a 40-year-old lady, she's here for allergy testing, and she's on Advair, and she used your albuterol 2 weeks ago. I'm like, yeah, get an ACT and a PFT, and then, come show me the results, and then if it looks pretty good, we'll proceed with testing. But are there other disease processes that might be a problem if you do spirometry? I personally haven't run into any of these, but they're out there. So did they just have some cardiac event? Did they have eye surgery? You're increasing a lot of pressure when you're doing this forced maneuver. So is anyone taking that into account right before they do spirometry? So just some other aspects that I learned as I put together this talk. Infection control issues, of course, COVID was COVID. We have viral filters which help, but if they're all coughing in the room, like why are they coughing? There's tuberculosis running around, there's other diseases. So again, how do we account for it if they're actually having active symptoms, but you kind of need to know what their lung function is? And of course, can they understand the directions? And we all know that some little kids can totally get it while the mature adult has no clue, and vice versa. So other considerations, you're going to ask a smoking history. Are we asking about vaping, and when did they last do it? That can affect lung testing, as well as potentially I don't know, is anyone doing exercise challenges and repeat spirometry, try to tease out the exercise-induced asthma, but if you're going to try to tease that out, well, you probably shouldn't have them go run an hour right before they do it, because maybe they diminish their lung function. And then finally, again, this is a max effort maneuver, so they should be in comfortable clothes. If they're really wearing tight clothes, they're not going to get nice full expansion. As I keep my shoulders back from our speech pathologist and try to speak with my abdomen and not my throat. I'm working on it. All right. And then, they probably have a history of asthma, most likely, and you're doing PFTs. Well, when have you last used these medicines? Because if you're going to talk about doing a pre and a post, these medicines can affect the pre and the post. So again, some nice little, key points there. If they're taking those medicines, just try to ask them, like, when was the last time you did take that medicine if you're going to do a pre and a post? All right, nose clip or no? Who has nose clips in their clinics? Who has their patients? Hey, you got to wear the nose clip, right? Well, so we have, I think, the Soft Snug here, and it looks all nice and cool. And this is quoted from the company. Proven results, unsurpassed comfort, the best price around, and better PFT results. Does it give you better PFT results? Sorry. So I did a little digging, and there's actually 3 studies that are out there that looked at different populations: men, children with asthma, CF centers, some more adult men and women, and basically did a nice kind of crossover study that did PFTs and did the nose clip actually affect it? Well, the bottom line is it didn't make a difference whether you had the nose clip or not. The differences were every effort, and you probably know this if you've been seeing a lot of spirometry, is every effort is slightly different. So there's a lot of intrapersonal differences in how that method is delivered. So if you want to keep doing the nose clip, no problem, but I don't know, I'm looking at Dr. Silver's. Maybe I can get 10% of what the company says by not buying nose clips anymore after this lecture. Making my stake now. All right, and then, we do PFTs, probably don't think anything of it, but it's not risk-free. There are incidents that can happen. Of course, syncope is the most common. Max effort, I've had people basically pass out on me and try to fall to the ground. You don't want them hitting their head. So whether you're doing sitting or standing, the current guidelines say they actually should be sitting down to do this, not standing up. It shouldn't change the lung function. You should have a chair with arms to give them a little support. And a lot of times they're on the exam table, and if they're short, their little feet are dangling there. So I'm just, their feet should be planted on the ground. And the other patient positions is maybe they have some other paralysis. The guidelines go, if you need to have them supine or on their side, there are ways to do it. But to me, in a chair with arms, feet on the ground. All right, moving on to, okay, we're going to now instruct them to do this PFT, right? Just like BLS, right? The scene is clear. Call 911. I know BLS and I'm here to help. Can I? All right, so now we're going to do this. So as I mentioned a couple times, it is a max effort. And it's all about the coaching of the patient, and you just have to keep refining your skills. Some key aspects, of course, is, can they put the device in their mouth and achieve a tight seal? Because if they don't have a tight seal, you're going to get air leak. You're not going to get a correct thing. And, I used to say you want to take a really deep breath. Well, no, you want to really take your max deep breath, like as much as you can. Not just take a deep breath, take a max inspiration. And that's, again, these guidelines, they specifically say, just take a deep breath. You're not really you're showing them what they need to achieve. And we're not blowing, we're blasting. So max inspiration and blast. If they're saying blow, tell them to say blast. Because it's going to be hard, forceful, it's not fun. And for kids, you want to have them at least try to do it for 3 seconds. And I got some PFTs from our company that'll be interesting to just see. And adults, you want to try them to at least do 6 seconds of blasting, 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 blasting. Keep going. You're doing a great job. Coach them through it. And some people with underlying COPD, they may take 10 or 15 seconds to be able to blast all that air out. So you got to. I'll show you on the curves that your machine will show you, how you can determine, did they actually achieve that end result. All right, so you're going to take that really fast max inspiration. You're going to blast, so you take that deep breath, and they can't hold it. Don't do that. You need to really blast within that initial 2 seconds. So no delay, blast away, encourage them through the effort. And then, how many times do we need to do this, right? So minimum 3. I will tell you, when I have a really difficult patient, I just tell my MAs, I'm like, just give me one good one, and I'll take it. But the standard is 3. Some people may need more, but they kind of say 8 is the max. So if you're just struggling and you're getting to 7 and 8, maybe you should stop sooner. But you can go up to 8 per the guidelines. And then, how are they performing it? So this is really small print. You should have some attachments. So this is straight out of the ATS and you'll see this on the machine if you haven't seen it before. Your little spirometry report, whether you're circling things or signing things or looking at it, there'll be a letter grade. And these letter grades are based on how they do. So you can see you won an A on the test, right? An A means you had 3 or more acceptable maneuvers. And the kind of, I call it reproducibility, is those efforts are within a certain volume of each other. They're not wildly different. And then you get lower and lower criteria as they do less and less well. So again, we want at least the 2 best efforts to be within 150 milliliters of each other. One little kind of nugget I've always used, and you'll see this as we show some of these, is I always look at the peak flow when I see it, the numbers. Okay, I got FVC, FEV1. Let me look at the peak flow. To me, you really want a peak flow that's probably at or above the FEV1 or FVC, because that says they blasted. It went straight up like a peak flow. And so you see a really low peak flow, way lower than their other FVC and FEV1. They probably did a blow, like a little mound kind of thing, and I'll show you that. And then as you'll see some of these curves, you really want that time volume curve to flatten out. It still shouldn't be detecting air. It should just not show you airflow after that last second of effort. Okay, so they print out the thing, they put it on your desk, and now you got to look at it. You might just look at the report that's printed from the computer, but you should be a little more technical, I would think. But kind of what it'll say, as well as a normal, or there's some obstruction or restriction or mixed. So this is kind of, I tried to cherry pick some things, but this is what we like to see. This is from one of those guidelines, although what I like to see, of course, is a inspiratory loop as well. But what this is trying to illustrate is you have these 3 trials, and all these, the top 2 are within 150 milliliters of each other. And again, as you look at how they blast, it kind of goes straight up, so you should have a really nice peak flow, and they're still blowing, 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 blowing. So. All right, so I've used some of these little acronyms. So just so you know, what are we talking about? The FVC is kind of that whole blast over that however many 3 to 15 seconds. That's what you're measuring, the forced vital capacity. FEV1 is the amount of air in that first second. It gives you a ratio, and just so you know, it comes out as kind of a decimal on the machine, but it's really what we're looking for. It's a percentage. And so as you're trying to input in the spirometry, you might put like 0.85 or 0.72, but that's correlating to more of a percentage. But realize these percentages are different for different ages. So keep the age in mind as you're looking at the ratio. And then I mentioned the peak flow is another measurement you'll see. And I personally, this is what I have my MAs put in. You can put in all the measurements, but I at least have them do these 4 things. All right, so sometimes what you'll see is if they hesitate, and instead of a nice, so green is supposed to be what you should see, but maybe they hesitate on their blast, and it kind of looks a little more delayed. And again, maybe your spirometer is going to tell you something, but again, the problem is it could falsely elevate things, and then you're not interpreting the lung function the way you hope you would on a normal PFT. This is what we see a lot of, which is the, I'm just gonna blow, I don't understand this blasting thing, so they're just gonna, so I can make it to 6 seconds because you're yelling at me, you know. So you see this kind of mound, and again, it can mess with your FEV1. Sometimes it doesn't even tell you, there's kind of something odd, but what you'll see in this, and I think I have an example, is that peak flow is not gonna be a high percentage. You have patients that are trying to struggle and they start coughing. The problem is if they cough within that first second, it might not even be a valid spirometry measurement. I think there was one case report, I can't remember how long ago it was, where sometimes is a telltale side of the ILO or the VCD when they're trying to blast it. Actually, you might have them do this, but they really shouldn't cough in that first second of the effort. We see a lot of this, which is you see a nice curve, and if you just look at this, you'd be like, oh, that looks really good. But then if you look at the volume time curve, they're blowing, blowing, blowing. They got to all of 2 seconds, and they just stopped. So, I mean, maybe that's all they can do, but that's not helpful because, again, it can falsely change FVC or increase the ratio, and now you're trying to think it's good data, but maybe it's not. So they really need to blast for a lot of seconds. All right, you're going to do a pre and a post. What are you using? You can use different things. It is all pretty much equivalent. It's kind of maybe a style thing or a time thing or what the patient has, or maybe you want to do some education to make sure they know how to use their albuterol. If you're going to use their own albuterol inhaler, you can use 2 puffs, you can do 4 puffs. I didn't really see any head-to-head like, oh, one is way better than the other. It's a range that's allowed. Or if you do a neb treatment, it's the 2.5 milligrams of the albuterol neb. And then you want to wait 15 minutes, you repeat the PFTs, and the bronchodilator change, there is a strict definition of this, where either the FVC or FEV1 is increasing by 12% and 200 milliliters, but there's some latest literature that says, well, that's pretty strict, and if you meet that strict criteria, that's great, but it doesn't necessarily mean there's not bronchodilator. And some pulmonologists and probably some of the allergists in the room will say, well, they'll say they don't have absolute reversibility, but they have partial reversibility. So there is some recent studies that say, well, we shouldn't be so rigid, and they kind of classified them. What do we do with that information? I'm not sure, but just realize there are people out there that are kind of trying to fine-tune what a bronchodilator response may or may not be. And then some people would do the Atrovent potentially. Some people seem to respond to that over albuterol. All right, for full disclosure, this is my PFT. Tried to play around with it. You probably tell me so maybe what I didn't do, but just so you see, so right, I'm in my office playing around for this lecture. I'm blasting, 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 hopefully enough time, and then a really maximal deep effort, so you get hopefully a nice deep inspiratory picture there. You will notice, I guess I kind of petered out here. Didn't get to 6 seconds. Probably could have gone a little farther because this didn't really flatten out. But I got some results here, and yeah, I'm pretty good. It's normal, but these are my numbers. Yeah, I think I do have some like residual excess residual volume somewhere hanging out in my lungs. But 80% above is what we like. Normal ratio, and that peak flow, that initial blast, this is what I personally key on, is that percentage greater than these. And when I see this is greater, then we really should see a nice blasting effort. any questions about my lung function. That would be a HIPAA disclosure, but no, I am not. All right, so, yeah.
When you're looking at it and trying to see the level of control over a period of time.
Yeah, I've always been that way.
I know, but I mean, do you take people off of bronchodilators and steroids for the day before, or you just take them random?
I mean, when they're coming in, I just get a baseline, and then I figure out where they're at and how do we put. I'll show you some other things here that'll maybe answer that question, that comment. So these are real world examples from our San Antonio clinics, and I just wanted to pick some. Like, here's an effort, right? I mean, what do you think? It's a great effort, right? No. It's like, I'm not sure yet I know what I'm doing with this. We get these numbers, though. I mean, they're awesome. I mean, 134%, 120%. Here's, again, where I key on. Obviously, this is not good, and you can see it play out because it's the mound, not the straight up. So, again, this is going to overinterpret your FEV1, and you're going to think, oh, that's normal lung function, although there are some comments down here, except with care, you know, it's grade of an F. Again, this isn't the fault of the provider. This is making sure our staff are doing it or getting the patient to do their best, and if we can't interpret it, we can't interpret it. But I'm not sure I would make clinical decisions so much so based on these numbers saying, oh, you're good to go. 134%, you should join the Olympics. Here's another one. I'm just taking them off our machines. So, but we did a bronchodilator, right? This was, I think the blue is the original one and the green maybe is the second one. But hey, they were more than 12% right here, FEV1, bronchodilator response. Maybe I'll have to up your Advair because you're not doing so good. But again, can we really believe this effort? Because I'm not even sure. I was trying to think, how could I replicate what the patient's doing? I mean, it must be like, but like, do you really want this to come to your desk, right? You probably don't. So this is where your staff that is doing this, or you're doing this, you know, just try to get better efforts. Some coding. So again, you know, you got your super bill, your MAs are coding this. Remember, whether you do a baseline spirometry or a pre and a post, you can only choose one, right? You got to pick your code. You can't put them both on your super bill. Those who do, I've never done ENO. I'd like to one day, but there's a code for that. And then in the little box in the section of Next Gen, you can click on the mouthpiece, or if you use a viral filter. And what I have my staff do is I have them fill out all the numbers and click the boxes, but I tell them, like, do not hit submit, because if they hit submit, you can't get in there and mess with it. So just tell them, do everything else, but don't hit submit, because I might change the diagnosis with that other box to click something other than an, you know, out of control asthma, mild, moderate, severe. Peak flows, again, if you want your patients to do it, it's not a bad idea. They can get a sense of it, but the idea is you take these 3 efforts, you take the best number. There's some diurnal variability, AM to PM as well, and so you do it over 2 weeks, and then there's products out there that they can do a little graph, and you can figure out what their peak flows are. But if it's more than 10% variability day-to-day in adults, or 13%, that's considered like, you got some variability, and maybe there's some more inflammation than we think. You know, there was I wonder, wow, a slide fell off, which was really, oh, wow. So the slide I wanted to show you actually was a classic case. I couldn't believe it. It's the worst asthma I've ever seen in 23 years. So if you can, picture, the kid comes in, he's 10, ACT is like 19. I'm here for allergies. Okay, we're going to do some skin testing, but you have this sort of history of asthma. Your ACT looks good, and sort of fortuitously, I'm examining him before we kind of place the skin test because he was a kid, right? We kind of have that horse before the cart. And I'm listening to his lungs, and like, it is tight. Like, there is no airflow. And I'm like, there's no airflow. And so, you know, so I'm like, well, let's get a baseline spirometer. His FEV1 was like 25%. And he did an excellent effort, and this is why it's killing me. I'll send you in the chat group. I'll show you the spirometry pre and post. So he had a great effort, nice peak flow. Air has taken a while to get. We did a bronchodilator. He improved by like 65%. Of course, his eosinophil count's 770. He's on allergy shots. We put him on mepolizumab, and he's doing awesome. And he had missed like 20, 30 days of school and on steroids left and right. Now his lung function baseline is in the 80% range. So again, it was just, I couldn't believe it. But his ACT, if you just took it at the ACT and didn't really do a nice physical exam, you probably would have missed it because he's like, I'm doing great, 19. Like, let's just test him, right? Maybe we won't get PFTs. So, yes, in the back. I'm sorry? I did not. I could, I guess. But he had such a great response. Yeah, I mean, it was classic to his bronchodilator, which I guess I'd have to think hard because I'm not an alpha-1 guru. I wouldn't think the bronchodilator really changed much with alpha-1. So,
Testing that day, or did you wait until he had the normal, or
I think I did end up skin testing him that day just because he improved so much. And I don't do intralymphatic to myself, but I am pretty aggressive if I can be. So I'm a different kind of aggression. All right. Peak flows, diurnal. So to me, the key points are the coaching is everything. So if it's been a while since you've been in there doing the PFT, those who raise their hands that, hey, we do it in the clinic, great. But those who haven't maybe been in the room for a bit, I would just encourage you, go in there from time to time, maybe supervise your MAs who are doing it, make sure they're getting good result. But when you see those PFTs, you know what you should see. And if you see otherwise, think about it. How's that affecting your practice and your education with the patient? And of course, we really want to use blast the air, not blow. And with max effort to breathe in, blast it out, and a max breath when you are, max effort to blast it out and then a max effort to breathe it in. Yeah, I dropped some slides because I also had a slide about 2 weeks on the job here. 16-year-old, you know where this story is going to go. 16-year-old who came in and was on like high-dose Advair, allergies, asthma, some anxiety. I'm having trouble breathing. Yeah, some slides got dropped. Classic blunted inspiratory loop, right? And just VCD right in your face. Was able to work with her, send her off to speech pathology, got her off all her inhalers, and like she was doing great. So you're going to catch these things. So definitely have the expiratory loop and the inspiratory loop. So, all right. So if people don't need to run to the airport, I'll be happy to take as many questions as time allows. Dr. Silvers. Mm.
Oh, I'm sorry, no, he's right. You can keep going, I just want to add a comment.
Yeah, so I'll keep you all informed of that, but electrolyte doing the same work in the same conditions.
And the only change is you want to make some comment on the interpretation, so normal inspiratory, expiratory loop, or inspiratory loop truncated, something like that. You just want to make some comment because it's interpretation.
Yeah, how would you say, Dr. Silvers, the provider should be? Is the documentation, I just write my name and a signature and it gets scanned in the record, or I'm circling what the machine says and initialing like I agree with that, or I'm actually writing a few more words about it? What would you say is kind of how you want?
I have in my asthma plan a couple different things we can choose from, whether there's obstruction, no obstruction, reversibility, non-reversibility, and whether there's 1 to the 4 time. So I kind of just add 2 or 3 sentences for every spirometry to do within that plan.
Yeah, I would encourage with all of your spirometry, whether it's peak flow, spirometry, whatever.
Actually, I have my thumb drive that might have the slides that got left, but I'll send it to you guys, right?
There's a flow volume code, and I don't remember what it is.
We will share it.
I'll figure it out, and I'll verify things first just to make sure we're not using kickback on that, but it may be a switch in how we code some things. Again, this is not for pre and post. If it's pre and post, you stick with what you've been doing. This is only for the pre-current
So instead of 94010, there's going to potentially be a different code we can use.
All right, hold on. Jessica, I'm going to come back to you, Dr. Makel. Jessica?
What, can you maybe touch again on the, what's the consensus of like we're changing up the medication, having them come back in a month, then should normalization of lung function if they're on ICS level? Are you having them stop it the night before testing, or you keep them on it?
No. Oh, I guess so. Maybe kind of where you were going. Sorry. Thank you. So I focus my talk on just this is how you should actually do spirometry. So if your question is, well, you showed this graph where you have to stop those inhalers because it may affect lung function, but your scenario is I have a patient who I've diagnosed with asthma, I put them on treatment, and I'm going to follow them up. They should stay on treatment because you want to know where their lung function is going. It's more of the, hey, you're walking in the door. Are we asking the last time they say they're on Advair? What, are we asked about antihistamines, 5-7 days. Are we asking about when's the last time you used your Advair? Just so you know that it could affect your lung function, but you'll kind of figure out, do I like normal or is it abnormal? Because if it's bad and they're saying I'm taking it every day, well, you're going to think about it differently than, oh, your lung function is totally normal. You're doing great. Your ACT is 23. We'll evaluate your other triggers for your asthma, and in 3 months, you ask the patient too, and this is totally separate talk, how long have you been on Advair? Oh, 5 years. Has anyone ever changed a dose? Well, no. So do you really need to stay on that dose of daily asthma medicine, or can we over time refine that so maybe you don't need as much to maintain control and lung function and quality of life, all those things in a asthma talk. Yeah.
And
You're really using the lung function as a test adherence, because if it comes out bad, they're not taking it.
or they need
I mean,
to
that
step
certainly
up.
can be one outcome. So, yeah, I mean, adherence, whole nother talk, people aren't adherent to their inhalers. Yes, in the back.
Have you ever had a patient that just can't do a good spirometry?
Totally. And I guess even the lowest age, in these guidelines, oh, maybe a 3-year-old could do it. I'm like, eh. To me, girls are better than boys, and everyone's got their own figure, but I'm thinking around 6 for girls, maybe 7, hopefully for boys, they can start figuring it out. But yeah, we have some adults who they have no clue. But you just try to do it. But the key thing about that is they don't get it. Well, let's bring them back in a month, because maybe we're not sure what we're doing in terms of management and management outcomes. So let's bring them back, and hopefully over time you keep refining their ability to do that effort. So, but you're right. Yeah, I have people they just can't figure it out, and I'm like, back to the patient understanding. I mean, you think they understand, but they just don't understand.
And there's always impulse oscillation spirometry, which is not effort dependent.
Yep.
We need to get a spire to pay for those units.
Yeah. And Jessica, to your point too, though you don't stop the patient, I usually mention it in my plan minutes, usually in there anyways, but you're taking that into account with your interpretation, so. Yeah. All right, Dr. Bakel, you had a question earlier.
Kirk, very often with a new patient, we do reversibility, and we find that the FEV1 only goes 3 or 4% better, or the FVC, but the FEF 25-75 shoots up 35, 40 points. So at that point, I'll pretty much assume it's asthma and treat, just based, even though we don't have the change of the FEV1 to make the legal definition. Do you see that often?
So I'm a hater in different ways. I hate missing previews at movies. I hate leaving the house late for the airport. And I hate the 25-75. So, but the problem is, I think if you look at the data, the 25-75, I think people talk about 50%, okay, maybe now you're actually getting something, but, okay, it's the measuring of the small airways, but actually it's the measuring of the 25 to 75 within the lung function. So depending on their effort, it may not exactly capture the small airways on how they do their effort. So to me, you have to interpret that with extreme care and maybe prejudice, but that's my take on it. It probably does have some value, but you want legit PFTs to be able to really say that's my true 25-75, because it's looking at the quadrants of their PFT, and if they shorten their effort and it doesn't go 6 seconds and it actually flattens out in that last second, it might not capture that accurately. And 0 to 100%, 25-75, what's significant? Okay. Oh, so I'm just looking at the MDs in the room just to pimp them. And one question, if everyone's asking a good question, like, is the 25-75, can I maybe rely on that better to manage my patient? What are we thinking is then significant? And so, right, it can range from 0% to 100% improvement. So I'm just asking all of us, starting with me, I don't look at it. I guess if I had to look at it, I'd say more than 50%. But I mean, number, Dr. Nutt?
I don't really have a number. I just look at it, I take kind of their clinical history into account.
So no number, okay. Number? Yeah, no number. No number. Dr. Silvers? Okay, he's going 50%.
Wait,
No number.
what were you saying, Dr. Murthy? You said no number, but.
Look at the number, but I do look at 25-75 and in correlation with the FEV1 and then make the decision.
Okay, no number. No, just, yeah. I mean, it is the gestalt of the patient and what are they on or not on, so. But again, I'm sorry, I'm a hater, I admit it. So you don't have to be a hater like me, but it's just one thing you can have measured, just make sure they're doing a correct spirometry for that good 6 seconds to capture that middle portion. Because if they only do 2 seconds worth, it's all in their FEV1, and of course, yeah, right. You know, and these questions are between you and the airport. I live locally, so I can stay here all day.
So what do you do with a patient who comes in, pre-bronchodilator's normal, post-bronchodilator crashes? How often do you see that?
From time to time, I think, right, they peter out. They can't.
No, they're still 6 seconds, but all the flows just drop drastically. How do you explain that?
It's above my pay grade. So your comment is the flow volume loops or the percent?
FEV1 over FEC is normal, pre.
The ratio.
Yeah, all those numbers.
Okay, got it.
And then after the post-bronchodilator, everything crashes, just falls to the floor. And it's still a curve. I mean, it's not choppy or anything.
Yeah.
But those flows fall after the bronchodilator. How do you explain that and what do you do with it?
I've never seen that. Did they pick up the methacholine instead of the instead of the albuterol?
I think that's a form of exercise-induced asthma from the forced vital capacity. That is exercise. And what I'll do is I'll have an anticholinergic if they're not on it. That's what I do.
And you've seen it go back to what you think it should do?
They do better.
Yeah. I mean, I have seen it where you do effort after effort and they just start going down because they just lose the ability to do a max effort.
That's all at the same time. So we're
Yeah.
talking about 15 minutes later after they've had the bronchodilator, and you look at in the flows, and they're dismal.
I've never observed that, but I you know. Yeah.
All right, any other questions? All right, thank you so much, Dr. Weibel.
Sure, thanks. Safe travels back to home.